Next, I invite Dr. Deepak. He will present his paper on a study on problems faced by residents in learning and performing external DCR. Dr. Deepak, give us 1 minute to grade the previous.
Please.
Hold for 1 minute.
Okay, sir. Chairperson and delegates, first of all, I feel you because I am jumped in between. In my SSTC area, there is short circuit, so I requested to go for early. My study is on what problem resident face during the doing DCR. As we all know, that DCR is a most common, almost the common surgery in the all the lacrimal surgery status, and mostly in medical colleges or the teaching institution. After some times, only the resident can do, and due course of time there are various methods which describe various success rates from 80 to 99% from the external DCR. So my aim is to find out what a resident can face or what we can change in the curriculum, because now NMC is also changing the curriculum and now we are become more and more objective based to perform and know real learning curves. It is a cross-sectional observational study done after taking a ethical clearance between the October 21 to September 22, and inclusion criteria was all the normal cases of obstructions, NLD obstructions, and exclusion criteria what we can say it is not a difficult case, means what we can say the cases are difficult for doing DCR, we excluded it, that all are the standard pro forma. And after that we created a questionnaire. Based on that we find out whatever the common steps, in which step they are facing problem. I am skipping these routine processes because these are already done at all the places before doing DCR surgery, and whatever the things we have to do during DCR surgery and after the proper treatment or surgical protocol we have followed as per the standard guidelines which everywhere is mentioned. So I'm just skipping this and going for the what is the problems they face exactly when they have do and at which step they are having some problem. Whatever the data was we got, we analyze it with SPSS 16 software, and coming to result directly, total 35 responses we got from junior and senior resident both. The age group we all know is the same, and 10 residents from first year, 10 second year and 10 third year, and 5 were the SRs. We included SR just because they are completed the third year course into the third year group, and we have 3 groups measure of them. And when we do, we find out that whatever the anatomical success rate we defined in our objective aims, it is almost 90% achieved when this surgery is done by the third year, and 75 to 80% achieved when it is done by first year and second year resident. And this is the main table which we are going to highlight, that these are the problems or the things we make as a common leading step in the DCR surgery. In the incision making, yes, out of 10 initially the 2 of the resident from the first year face the incision making problem, but second year and third year usually didn't face angular vein recognition or some issue related to them. It is again I am saying what we can find out is the most common problem in the first year when they are going to recognize. Although these all surgeries are supervised by a trained person, we are going to identify which problem is going on. So initial 3-4 stage problem like incision, angular vein recognition and identification, nasal packing and suturing, all these problems are common in the first year. But from the second year or third year onwards, who had did 25 surgeries, we have taken that in the second year or the third year, these residents at least do 25 surgeries in the first year, then second year, then third year. So after doing 20 to 25 surgeries, these problems are not reported by anyone. Bone cutting is still a problem for the second year, nasal mucosa and cutting of flap, but these 2 problems again not encountered in the third year when we have means they have done the 50 surgeries. But whatever the fistula is that, but when insertion of the tube or another type of cosmetic problem with suturing and other thing, it is again after doing the 50 surgeries means third year also face. So we can simply conclude that whatever the anatomical and functional success rate is, that if any resident can get 20, then few steps reduces, next 20, another few step reduces. And what we can recommend, there are the many discussion and study previously done by another authors who shows various type of a number of surgeries should be performed to become say more anatomical success rate or the better one. And we can recommend in our study that 20 to 20 means after doing a 40 to 50 surgeries, the complication rate is significantly low as compared to the first year's one. That is our study, and we recommend that not only 2 or 3 cases, although there may be a surgical hand variation in each and every one, but for the masses, at least 40 to 50 surgeries should be given or should be performed under the observation. Then after only we can give a free hand for any resident to perform the surgery. These are my references. Thank you, sir. Thank you, everyone.
Thank you, Dr. Deepak. So you have analyzed a good one, like relating to the residents. But one thing is that because we have trainers for them also.
Yes, sir.
So I think how many total cases the resident have done by 3 years?
Sir, our places are in our study.
In your study,
Sir, 60.
there is a minimum or there is a variation for each resident? How many
No,
you
sir.
have taken?
Variation for each and every resident, but what those number of resident we included them, we ideally give equal number of cases in first year, second year, and third year.
Okay.
Those-
Because the main problem here is the flap, where
Yes.
you are creating a flap, anastomosing it.
Yes.
And how about the fistula? I was not clear about it. Fistula.
What, sir?
Fistula. You have written fistulas, something.
Sir, fistula making means those who have done the that one flap and suturing everyone, they are not able to maintain that nasal flaps and other things. These are the simply the flap related issues, means blockage or the closing that will occur.
So even that includes the skin incision.
Yes, sir. Yes, sir. That anastomosis part is there, sir. That
Yes.
anastomosis,
Yes.
even after doing 40 surgery, the resident faced the problem in that one, lacrimal suturing.
So I think that is a very important criteria to have a success rate, like anastomosis and
Yes, sir.
making of flaps,
Flaps.
and closing it. So
Yes.
that is what gives the success rate for the DCR. If that is not met, I think it is a deficiency.
100%, sir.
Understood.
If we not get the patent path, then how we can assess? But we our
Yes.
so many.
So
Sir,
So
the
the-
aim was only to just know means how much surgery at least we give. That is sir minimum. Maximum is not a criteria. But when we have jump means 20 surgeries, then we find out after doing 40 or 20 surgeries, the complication rate reduces. It is just an objective method because nowhere it is written that everyone is saying complication rate is less in expertise hand. But how much surgery anyone can do to become expertise, that study is basically to just quantify the number so that we can have some idea in that if we can go by this number of cases, then rates will be the come as per our study, sir.
thank you.
Thank you, sir. Thank you, sir. Thank you. Thanks a lot, sir, for giving me opportunity.